Hello, everyone. My name is Rina Mauricio, and I'm a cardiologist with a special focus on women's cardiovascular health at the University of Texas Southwestern. And I'm the writing group chair for the AHA scientific statement assessing and addressing cardiovascular and obstetrical risks in patients undergoing assisted reproductive technology. I want to thank the American Heart Association for commissioning this scientific statement.
My name is Arthur Jason Vaught, and I am a maternal fetal medicine specialist and a surgical critical care physician at the Johns Hopkins University in Baltimore, Maryland. And I would also like to thank the AHA and our writing group.
Jason and I wanted to start by talking about why this statement. So, from a cardiology perspective, the number of individuals who are utilizing assisted reproductive technology is growing, and a growing subset of those individuals are those with cardiovascular disease. Now, cardiology providers are increasingly being asked to assess these individuals with either cardiovascular disease or risk factors for cardiovascular disease prior to beginning assisted reproductive technology. Unfortunately, however, the data in this space is really limited and guidance for the clinician is sparse. So one of our goals for this statement was to provide guidance for the cardiology provider and highlight areas where additional research is needed. And I want to let Jason talk about how this statement is helpful from an OB perspective.
Thanks, Rena. It's really helpful from an OB perspective. A lot of our cardiovascular patients, secondary to medical, procedural, and surgical interventions, are living longer and reaching life's milestone. They're graduating from schools and subspecialty education. They are forming long-term relationships, and they are seeking out another life milestone, which is building a family. Now, from an OBGYN, reproductive endocrinology, or maternal fetal medicine specialist standpoint, it can be really overwhelming when someone with complex cardiovascular disease, whether it is congenital or acquired, comes to us stating that they want to start a family. We want to support our patients the best way we know how, and having this document serves as a starting point for that conversation, just not with our patients, but also with our cardiology colleagues.
Now, one of the main points that we wanted to cover was to first also talk about the ART process, and so at least for cardiologists, that's something that we haven't thought about in a long time. I'll let Jason walk through one of our figures.
Yeah, when it comes to the ART process, it's really, really complex. And trust me, it's just not cardiologists that haven't thought about it in depth for a long time. Even myself as a maternal fetal medicine specialist, patients come to me pregnant, so I even need a little bit of a recap. So let's start there with figure one. So first we have the gonadotropin injections. This is basically to optimize enough eggs or oocytes to be retrieved. Then the person will go on to transvaginal oocyte retrieval, and at that point, the person or the family will decide if they want to have cryopreservation or if they want the egg fertilized for fertility. At that standpoint, they usually will go through an embryo transfer, and the other eggs or embryos that were not used will go for cryopreservation. Now, when we look at the risk factors associated with all of these processes, there are some that are there. From the gonadotropin injections, there is increased risk of ovarian hyperstimulation syndrome, or OHSS, in a hypercoagulable state, secondary to the exogenous estrogen and progesterone that are given. From transvaginal oocyte retrieval, there's always a risk of bleeding with procedures, but this can be increased for the cardiovascular patient who may be on large doses of aspirin, Plavix, or other sorts of anticoagulants. Then, of course, you have risk of multifetal gestation for any type of embryo transfer, and risk of preeclampsia and multifetal gestation for frozen embryo transfers.
And while there have been several statements that have talked about how to assess, counsel, and manage patients with cardiovascular disease prior to pregnancy, nothing exists thus far prior to assisted reproductive technology. So, as Jason and I were discussing, one of the things that we really wanted to highlight in this paper, or at least one of the tools that we wanted to give providers when they read this paper, was to know how they can assess and counsel patients prior to ART. So for that, we have provided our central illustration. We've divided it into three portions. The first is evaluation and counseling prior to assisted reproductive technology. We emphasize there the importance of a multidisciplinary cardio-obstetrics team, which can include MFM, cardiology with an ACHD specialist if appropriate. And then to begin with, to risk stratify the patient for pregnancy according to established risk scores, the modified WHO scores, the HARA score, or the Cartwright score. And those individuals who are at prohibitive risk for pregnancy, we can talk about whether or not they would be at prohibitive risk for oocyte retrieval or just pregnancy. And those who are at prohibitive risk for pregnancy, we can then discuss with them utilizing a gestational carrier or other options for building a family. Prior to ART, we also recommend reviewing medications for teratogen and those that may increase bleeding or thrombotic risk. During ART, we have now divided it into oocyte retrieval and embryo transfer. As Dr. Vaught had mentioned, one of the risks with ART is ovarian hyperstimulation syndrome, so we recommend using GnRH antagonist protocols to reduce that risk. And also for patients who are moderate to high risk by the modified WHO criteria, either class 2 to 3 or 3, performing some procedures in a hospital-based setting, just so that there's more support for the patient and the care team. And lastly, after we talk about oocyte retrieval and embryo transfer, we then discuss what to do afterwards. For some individuals, they may need to undergo repeat procedures, and if that's the case, either resuming those medications that were being held or discussing the plan to resume them if those repeat procedures are planned. And we briefly discuss management during pregnancy, but again, as has been discussed before, there have been multiple guidelines and statements that have talked about pregnancy, but our focus really with this statement was on assisted reproductive technology.
You're absolutely right, Rena. There are so many different ways to build a family, especially with assisted reproductive technology. And the cardio obstetrics team or MFM or cardiology provider may think it's safe for the patient to both undergo oocyte retrieval and embryo transfer and then go throughout pregnancy. And that's wonderful. But not every complex cardiovascular patient will be able to have that option. And it's really important to tease out how that process will go for that patient. This process is different from patient to patient, so I can't give you the exact step-by-step through this video. But again, there usually is a blueprint for this. In saying that, if it is deemed that a patient is safe for oocyte retrieval but not embryo transfer in pregnancy, obstetric providers should be able to assist the patient in looking for gestational carriership, and if that is not an option, even adoption. I think it's also really important to talk about the fact that oocyte retrieval, embryo transfer, and even storage of oocytes and embryos could vary from state to state. And that's something that's really important for providers to talk about with patients before starting the process.
Other things that we mentioned in the scientific statement, we provide some specific details on how to manage specific cardiovascular disease processes, what testing to do beforehand, things to watch out for during the ART process, and what to monitor for after. And as we had mentioned, this statement is really a starting point for providers, and we wanted in it again to highlight the importance of a multidisciplinary team, and furthermore to illustrate to the reader that really more research is needed and a collaborative effort between REI, OBMFM, and cardiology in order for us to gain more information on how to care for this growing patient population. I want to close by thanking the writing committee for all of their hard work on this scientific statement, and I'll let Jason have the final words.
Thanks, Rena. You're right. Collaboration is certainly key in this. And the collaboration could be just between an OB provider and a cardiologist, or it could span from an OB provider, MFM, a maternal fetal medicine specialist, certainly reproductive endocrinologist, and cardiac anesthesia. It's all in what the supports that the patient need to help achieve a safe and healthy family. Again, I would like to thank the AHA and thank you for listening to this discussion.
Thanks, everyone.